Hello everyone, I hope and I believe all of you are fit and fine. So today we learn about allergic rhinitis. We always have one person that we know in our family or in our friends group that he or she is always having common cold, always rhinitis, always sneezing, always having headache and always nasal blockage. So today we learn about that person, that what is the actual problem. Can you tell me what is the allergic rhinitis? Allergic rhinitis is type 1 hypersensitive inflammation of the nasal mucosa, which is induced by exposure to allergic substance and with at least 2 of the 4 cardinal nasal symptoms such as sneezing, rhinorrhea, nasal itching and nasal block present for more than 1 hour per day on most and many days in a year. Allergic rhinitis is very common, affecting 10 to 30% of adults and 40% of children. Almost 80% of asthmatics have associated allergic rhinitis and around 50% of allergic rhinitis has associated asthma. So here we learn culprits or the triggers or the root cause or allergens which causes allergic rhinitis. Aeroallergens, dust, animal and insect allergen, house dust mites, cockroach and pet dander, occupational allergens, latex, indoor and outdoor pollutants, and drugs like aspirin and other NSAIDs can trigger the allergic rhinitis. Basically, this allergen causes two types of allergic rhinitis, intermittent and persistent. If symptoms less than 4 days per week or less than 4 weeks per year, it is called intermittent. And if symptoms last for more than 4 days per week and more than 4 weeks per year, it is called persistent allergic rhinitis. According to severity wise, there is mild allergic rhinitis which is no interference with daily activities or no troublesome symptoms, while in moderate or severe allergic rhinitis, there is at least impaired sleep, impaired daily work, impaired activity, impaired school and troublesome symptoms present. So tell me the symptoms of allergic rhinitis. Here we can see red, itchy, watering from the eyes, sneezing, congestion and runny nose, itching and sore throat, cough and post-nasal drip, itchy ears and buzzing sounds can be heard. So here are the typical physical findings we can see in the every case of allergic rhinitis. If we can see, these are the dark circles under the eyes due to congestion of nose and sinuses. We can see open mouth with recessed lower jaw due to mouth breathing if nasal blockage is present, and Denny Morgan lines also present. These are the transverse crease over the nose, results from frequent upward pushing of the nose, which is very characteristic of allergic rhinitis. It is also called allergic cellulite. There are many more problems and comorbidities which can occur due to allergic rhinitis, primary and secondary comorbidities. In these people, allergic asthma is very common. 50% of the person with allergic rhinitis will also have allergic asthma. Other complications are sinusitis, otitis media with hearing loss, conjunctivitis, laryngitis, atopic dermatitis, URTI, obstructive sleep apnea, and secondary complications are decreased quality of life, adenoid hypertrophy, snoring, dental malocclusion and learning and attention impairment. So my question is, how to diagnose these patients? So detailed history, characteristic signs and symptoms and confirmed presence of allergen specific IgE is important, but tests like total eosinophil count and total IgE lack sensitivity and specificity, so it is not recommended routinely. Allergic rhinitis occurs in genetically predisposed persons. So what are the prevention measures we should take in these patients? Avoid areas with high pollen, fungal and dusty environment, strict implementation of pest control measures and controlling of house dust mites, because most common and universal allergens are house dust mite. Reduction in relative humidity below 50% is very useful to control this allergen in the environment. So first treatment is education of parents and patients, avoidance of allergens or triggers and pharmacotherapy. So in the mild variety, intermittent variety, second generation antihistamines given SOS, and in mild persistent allergic rhinitis, second generation antihistaminic Plus, intranasal steroids can be given. In moderate to severe cases of allergic rhinitis, if intermediate variety, then intranasal steroids plus leukotriene receptor antagonists such as montelukast and immunotherapy can be given. In persistent cases, nasal saline irrigation, intranasal steroids, leukotriene receptor antagonist, immunotherapy can be given. In severe rhinorrhea, ipratropium nasal spray can be tried. So here are the example of second generation antihistaminics. This is drug of choice in mild intermittent allergic rhinitis. Cetirizine, desloratadine, fexofenadine, levocetirizine, loratadine, ebastine, rupatadine and bilastine can be given. And here are the example of inhaled nasal steroids. These are given in more than 2 years of age. Examples are mometasone furoate and fluticasone propionate. It is given at 50 microgram per nostril OD in 2 to 12 years of age and more than 12 years of age, 100 microgram per nostril OD given. Allergen specific immunotherapy or desensitization is recommended in difficult to treat moderate to severe or persistent allergic rhinitis. Sublingual and subcutaneous immunotherapy can be tried in these cases. Thank you.